Hello, everyone. Welcome to today's CalMap webinar on SSRIs, or selective serotonin reuptake inhibitors, and cognitive behavioral therapy. I'm Joanne Jung, general pediatrician, senior associate director here at CalMap, and it's a pleasure to have all of you here for our webinar today. Before we get started, just a couple of quick housekeeping items. We are keeping the lines muted just for a better viewing experience for all. And we are reserving the last 15 minutes or so for our audience question and answer. So as you're listening, if questions come up, please use the Q&A little Zoom feature to share your questions with us. And we'll be sharing those with our speakers for the last portion of this presentation. And please be sure to stay on till the end if you want CME credit, because that's when we're going to be showing how you claim that credit. We will be recording this session. We will be sharing that recording on our website along with a PDF of the slides as well. So stay tuned and look on our website in a couple of days and you should be able to see those there. Quick word on our disclosures, and the short thing is that we don't really have any major financial conflicts of interest to disclose. You can see who our planners for the activity are, as well as our speakers for the day. And a quick thanks to our sponsors as well. So we have federal and state grant funds that help to bring all this educational content here to you. And so with that, I want to quickly introduce our speakers for today. We're fortunate to have Dr. Charmi Patel Rao, who is a board-certified child and adolescent and adult psychiatrist who trained at UC San Diego and at UCSF. She is the medical director at Vista Health Foundation, a nonprofit organization in San Diego that has multiple behavioral health and substance use treatment programs for youth and adults. She has also developed an expertise in early childhood mental health and comorbidities between developmental delays and mental health. And in pursuit of these interests, she had 11 years of direct clinical care experience in San Diego County System of Care. She was a supervising psychiatrist for juvenile forensics within San Diego County Behavioral Health Services, Children, Youth, and Families for 2 years. She is also a health sciences assistant, clinical professor at UC San Diego Department of Psychiatry, and enjoys teaching medical students and psychiatry trainees. She is the lead chair for Critical Issues in Child and Adolescent Mental Health Conference. We are also fortunate to have Dr. Lauren Hack, an associate professor, a clinical psychologist, and the chief of the School Age Youth Division in the UCSF Department of Psychiatry and Behavioral Sciences. Dr. Hack currently serves as associate director and school consultation lead for CalMap. And at UCSF, Dr. Hack is also associate director of the clinical psychology training program and co-chair for the Diversity Committee Research Subcommittee. She is the director of the Strive Lab and leads several clinical research efforts focused on improving family access to and engagement in school-based mental health treatment domestically and internationally. And with that, I will turn the virtual mic over to our first speaker, Dr. Patel Rao.
Thank you, Joanne. Nice to see everyone here today. As a review of our learning objectives for our time together, we are going to describe 3 commonly used SSRIs, including usual initial and target dosing. We are going to talk through how to explain SSRI risks, including common side effects and the risk of activation for our families, and talk about and apply language pearls for patients and families when discussing anticipated benefits, risks, and benefits. And then Dr. Hack is going to be talking about identifying 3 ways to coach patients on how to take actions, making behavior and environmental change, and restructure thoughts to improve mental health challenges like anxiety and depression, and how you can encourage that in your office. Oops. There we go. Okay. Apologies for the little bit of a tech issues here. So this is actually from our CalMap website, and it kind of outlines a depression treatment algorithm. I know it might be kind of small on your screen, but in previous webinars and echoes, we've talked about how to assess for and diagnose depression in the primary care setting. And so what we're going to talk about today is the medication treatment part initially, and then therapy afterwards. But a lot of this is based on the initial screening and assessment, and then categorization of the level of depression based on symptoms, based on a level of impairment. And medication can be part of that at any of these phases, but typically when we're talking about mild to moderate depression, we'll typically start with therapy first as a first recommendation. And when it's moderate to severe depression, we will consider therapy and medication as a first line intervention. So, when to consider prescribing in the primary care setting, right? Because often we'll think about referring to psychiatry, but sometimes it could be appropriate to start this in the primary care setting. So when you have uncomplicated depression or anxiety that progresses, like I said, to more moderate to severe, it could be something that started in the PCP office, especially, even if the long-term goal is to transition to a psychiatrist, it could be something to start as a bridging piece. When there's significant impairment, then we want to think about prescribing medication. If there's been failed or partial response to therapy and other supports, that might be a time to think about medication. Obviously, the parent and the patient have to agree, and there has to be education on medication risks and benefits. You have to be able to know and monitor the patient well in order to be thinking about doing this. This is not something to do in the patient that you see once a year for their well child exams. And be able to consult and collaborate as needed. If, for example, they are working with a therapist already, it can be helpful to connect with that therapist if you're thinking about prescribing medication. This particularly can be useful, especially with teens who, typically know their PCPs well if they've been lucky to have the same PCPs since they were babies. And might be reluctant to seek help from another provider, a new provider, right? And so they might feel more comfortable coming to their PCP for treatment. And so it is nice to think about developing that comfort and so that there isn't a delay in treatment for patients who could benefit. Oops, sorry, jumped too fast. In terms of general principles with medication, you want to start low and go slow, especially if there's co-occurring anxiety with the depression that can help reduce the risk of some of the side effects that we're going to talk about later. It's also important to understand there is limited FDA approval for medications. It doesn't mean that we can't use these medications, but we have to just talk with families about that they're being used without the FDA approval because there is good evidence that there's similar efficacy across the whole class of SSRIs, and so whether or not a medication specifically has the FDA approval is less important. The ones that do have some FDA approval are fluoxetine, escitalopram, and sertraline. Also, duloxetine, which is an SNRI, does have approval for generalized anxiety disorder. It's important to keep in mind that it can take 4 to 6 weeks at a therapeutic dose. That part's important because we typically start lower than a therapeutic dose. So we have to get to that therapeutic dose before that 4 week clock starts. But it can take 4 to 6 weeks at a therapeutic dose to see an improvement. If there's no improvement when we get to 6 to 8 weeks at a therapeutic dose, we might want to consider changing medicine to another medication. And if we have titrated up to kind of a moderate dose and there's some improvement but not complete remission, we can increase the dose even more to try to target that complete remission as long as it's being tolerated. So these are important principles we want to keep in mind. Just briefly, when we talk about kind of things like response remission, I'm not going to go through all of these, but response means some symptom improvement for at least 2 weeks. Remission is where there's very little or no symptoms remaining, and that's always the goal is remission. And then we want to sustain recovery and prevent relapse. The thing that we have to think about too is recurrence of depression. This is more important as we get into late adolescence and adulthood, that this is something that we typically we will consider tapering off of a medication when somebody is in recovery for an extended period of time. But if somebody's had several recurrences of their depression or anxiety, we might get to a point where we think we want to stay long-term on this medication. Okay, in terms of some studies that support the idea of medication for treating depression, the TAD study, which is the Treatment of Adolescents with Depression study, looked at a combination of fluoxetine and CBT, fluoxetine alone and CBT alone, and placebo. And what it found out was that the combination was more effective than either alone. Second to the combination was fluoxetine alone, and then CBT was better than placebo, of course. The TORDIA study, which is treatment of resistant depression and anxiety, looks at if somebody doesn't do well with one SSRI trial, what would be the most effective second line intervention? And what was found is that when you switched medication, if you add in CBT, add in therapy, there was a higher response rate than just switching the medication alone. And so even if somebody didn't start therapy during their first medication trial, if you're making a switch, that's another opportunity to kind of pitch about adding in therapy because there could be a greater chance of improvement with symptoms. In particular, it showed that there was greater improvement with symptoms like anhedonia, substance use, family conflict, when you added the combination of therapy and medication. And then lastly, the ADAPT, adolescent depression, adolescent depression, antidepressant, and psychotherapy trial, that's a mouthful, study showed that when one looks at primary response measures, that there actually wasn't a difference with the SSRI and CBT versus SSRI arm alone. But the key to that one is the primary response measure. So that's looking at those key symptoms of depression. But when you look at the psychosocial effects of somebody's depression, adding in therapy is definitely improves those things more than the medication alone. So this is, I know, a busy table, but kind of there's some important things in here. It just sort of talks about the different SSRIs in terms of thinking about which one, because often one of the questions that comes up is if I have a drug naive patient, which one do I start with? I think some providers have a favorite that they typically like to start with, and I think that's fine. If there is a strong response to an SSRI in another family member, like a parent, a sibling, that might be a good place to start, even if it's not one that's FDA approved. So say somebody's on citalopram, that might be a good place to start if there's a strong family history, because we know that can impact, genetics can impact how somebody responds to medication. Alternatively, would recommend starting with fluoxetine, sertraline, or escitalopram because they do have those FDA approvals. Fluoxetine can be considered if medication adherence is a concern because it has a relatively long half-life. It can be more activating, so somebody who has maybe some poor motivation or lethargy, that might be a place to start as well. It's typically a medication you would give in the morning. If somebody is on other medications, it would be important to just monitor for drug interactions with fluoxetine because it does have some because of the 2D6 inhibition concerns. So then the other options would be escitalopram or sertraline. Those have fewer drug interactions, and so one of those could be a good option as well if that is a concern. And then these other ones, citalopram, paroxetine, fluoxamine, are other good SSRIs as well. I typically avoid paroxetine just because it has a pretty short half-life, and so there's more concern about some of the side effects or discontinuation symptoms that can happen during treatment. It also has high levels of drug interactions. So another busy table, but this one is also important in terms of thinking about starting doses and target doses for some of the medications. So just to kind of talk through a couple of these, if you're starting fluoxetine, typically would recommend starting at 5 milligrams if the child is under 12, 10 milligrams if the child is over 12. A typical titration schedule would be for an over 12-year-old could be 10 milligrams for 2 weeks and then increase to 20 milligrams for 4 to 6 weeks and assess response. If there's a partial response at that point, can consider increasing further to 30 milligrams. And if there isn't a partial response at 4 to 6 weeks at 20 milligrams, then would think about switching to another medication. The same sort of logic can be applied to some of these other medications as well in terms of how to start and how to titrate those medications. Before we start medication, though, we want to make sure we're talking with families and client and patients about the education, the reason behind the medication, what we're targeting with the medication, things like that. Obtaining consent from the guardian and documenting that, and assent from the youth, right, that they are agreeing to taking the medication. If needed, it's important to have a safety plan in place if there's any concern about suicidal ideation or self-harm. And then kind of thinking through the schedule of visits, and some of that we can be creative about. It can be a telephone visit or a message in the kind of chart system that you have with patients, or a nurse visit, but a way to check in on how they're doing during that titration process. Sorry. Yeah, sometimes it sticks. Okay, there we go. And I'm going to spend a little bit of time talking about psychoeducation because it is really important to talk about, the causes, symptoms, course, different treatments for depression, to get that informed consent. Thinking about risks of the treatments, but also risk of not treating it as well, right? Because there can be a risk of further worsening of depression. Um, and, thinking about using motivational interviewing skills if there's hesitation about treatment, whether that's medication or therapy, using motivational interviewing skills can be helpful in terms of moving forward with treatment. Obviously, education can include written material and reliable websites. We have some great resources on the CalMap website that you can print out and hand out to families. And what is known, this has actually been researched, is that providing the psychoeducation, taking those few minutes to do that, can improve adherence to treatment. And so I think it's worth spending that time at the beginning of treatment. And it can reduce depressive symptoms on its own. I think somebody understanding their depression can help them in terms of those first steps for treating it. So, okay. We talked a little bit about this before about kind of having informed consent. One thing to keep in mind, and I know this doesn't come up very often, but if you're working with a foster youth, there is a county-specific process for obtaining court consent for psychotropic medication. And that part's important because I think we're not, pediatricians, we're not used to having to obtain consent in this way for other medications for foster youth, but it is important for psychiatric medications. Okay, so now talking a little bit in more detail about SSRI side effects, because this is something that's going to be important and again will improve adherence. I think spending the time talking about that. We're going to review them in kind of chunks, starting with common and mild side effects, and then talking about the more serious ones and less common ones. It's helpful to review that uh, the mild side effects that can occur are typically short-lived and time limited. And without sounding minimizing about it, try to encourage patients to push through and manage the symptoms as needed. So if they experience headaches, they can take some medication to help with those headaches. Typically would start with acetaminophen. And if they have GI upset, maybe trying to take the medication with food, because, reminding them that these side effects are typically short-lived. If there is a challenge with sleep, like if they feel like the medication kind of wakes them up, then they can take the medicine in the morning. If it makes them feel sleepy, they can take the medicine at night. That can be a helpful change as well. In terms of less common side effects, there's can be this increase in agitation, restlessness, which can look like anxiety. It's not anxiety, but it can feel like anxiety to the person. It's kind of like the physical restlessness that can feel like the physical symptoms of anxiety. It's typically self-limiting. What I always do in those situations is just stay at the dose that I am at with the patient, or maybe even lower down a little bit just to give it some time, let that resolve, and then continue with the titration process. Unfortunately, this side effect can be more common with younger patients and autistic patients, and so it is just something that we have to explain and monitor for. Starting low, going slow can be a good way to kind of overcome this. And can, but it's something that can happen, unfortunately. So, and then there's kind of these other things that we can talk about, if there's these other side effects that happen. These again are on the website as well. In terms of the black box warning, we're going to talk about that a little bit more in the next couple of slides. But there also can be, increase in appetite potentially, increase in bleeding time. I actually had a consult question last week about the concern about bleeding time. So the caller, the pediatrician, had a patient who was on Zoloft and was the patient was having some headaches and it didn't seem related to the Zoloft because the timing was different. And acetaminophen was not helpful. And so was inquiring about, is it okay to is it okay to be to for the person to take ibuprofen for their headaches. And because ibuprofen also has a bleeding risk. And what we discussed is that while both medications technically can increase bleeding risk, the risk is highest when there's long-term high dose use. But it's okay to take kind of low to moderate doses of ibuprofen on a short-term basis for those headaches, and that would be okay. But this does come up sometimes. And then we're going to talk a little bit about the serotonin syndrome in another slide as well. So this black box warning came out in 2004, and the idea is to make aware that there's an increased rate of spontaneous reporting of suicidal thoughts. And it's clear that's not an increase in suicides or suicide attempts. In fact, antidepressants reduce the risk of suicide and suicide attempts. It was actually found that SSRI prescriptions for youth decreased by about a quarter in both the US and the Netherlands after 2004, after these warnings were issued. And then not as a result, but what happened after is in the Netherlands, the youth suicide rate increased by about 50% between 2003 and 2005. In the US, the rates increased by 14% between 2003 and 2004. And the concern is that this is related to providers feeling less comfortable prescribing these medications. There are several thoughts about the mechanism behind the increase in spontaneous reporting of suicidal thoughts. One thought is that it's related to the side effects, like this thing that we talked about with activation and restlessness, where somebody might feel this improvement in their energy levels before there's an improvement in their depressed mood. Another thought is that when a patient is taking antidepressant medication, they're seeing a provider more frequently, so there's more of a chance to talk about those suicidal thoughts. For me, actually, as a provider, I think it's good when somebody's sharing these thoughts and not keeping it to themselves. I actually worry more when somebody has suicidal thoughts and doesn't disclose them. So I think it's important to tell families about the existence of the black box warning, of course, but also share that there's evidence that not treating depression can carry its own risk when it comes to suicide, and reassuring families that in the majority of cases, there isn't an increased risk of suicidal thinking or behavior, but just monitoring closely, encouraging families to monitor closely. The checking in routine can be really helpful, even for the family to do that internally. About side effects and any concerns about suicidal thinking. We know that asking about suicidal thoughts doesn't create suicidal thoughts, right? Those thoughts are there whether you ask about them or not. And again, it highlights the importance of that checking in and also of kind of starting low and going slow with these medications. So just briefly, because this probably will not come up for you guys, but if it does, it's like this board question that comes up sometimes. But I actually don't think I've ever seen serotonin syndrome in my practice. I've had concerns about it. So it's very rare, but it's important to be aware of the symptoms just in case you see it because it does require emergency intervention. It's definitely something to monitor for if your patient is taking other serotonin agents like dextromethorphan, again, long term, right? Short term for a cough is completely fine. But long term, it's something to think about. Trazodone, mirtazapine, just want to make sure you're monitoring for these things. So symptoms of serotonin syndrome include agitation, hyperreflexia, myoclonus, and other things. Mental status changes such as confusion and hallucinations. If it's recognized or if there's concern, we want to stop the medication and then admit to the hospital for monitoring supportive care. And that part's important. NMS is not something that happens with patients who are taking SSRIs alone. It's something that can happen if somebody's prescribed an antipsychotic medication, but the symptoms of serotonin syndrome and NMS can look similar, hence why it shows up as a board question. In terms of monitoring for visits, so we talked about this being important. In the first month, you want to make sure you're having very regular check-ins, ideally weekly, and they don't have to be in person. It can be phone, via the chart messaging. And the reason is the beginning part, the beginning titration is where there's a higher risk of side effects developing. And so that's why you want to kind of monitor and encourage them to push through when it is appropriate to encourage to push through. Um, and at the beginning part is where you're going to increase the dose more frequently because you're titrating up. The second month, you want to continue with regular visits, and then, hopefully they're starting to see the therapeutic effect. And then moving forward beyond that, monthly can be fine, and to make sure that things are going smoothly with the dose that they're on, kind of more stably. So we did talk about this a little bit earlier, in terms of this activation akathisia. There's a lot of different names for the kind of symptoms that we're talking about, but it's this kind of more physical side effect that can happen that can feel like physical restlessness, irritability. Sometimes somebody can, the families can feel like it feels like a worsening of their symptoms, right? There's more behavioral activation, there's more mood issues going on. And again, I know I keep repeating the same thing, but starting at a lower dose and titrating slowly can be helpful. If the side effect does develop, going back to the next lower dose can be helpful to see if it resolves and then increase the dose. If for some reason it continues and it's causing impairment, then changing to another medication is something to consider. If the medicine otherwise is helpful for the anxiety and depression, adding propranolol can be helpful for this particular side effect. So that is also an option. And so when we think about behavioral activation versus bipolar switching, this is important to think about. The activation is a more common side effect. Bipolar switching is less common, but it's something to think about, in a situation where somebody's presenting with these kinds of symptoms. But there are key differences. So bipolar switching typically occurs later in treatment, not during that initial titration phase. And there's mood changes as well, not just kind of like a physical discomfort, physical activation phase. And it's important to think about family history for bipolar disorder and other things like that, if that's a concern. Um, the non-SSRI medications can be also considered if we're doing a switch from because of the behavioral activation. So we talked about this a little bit, in terms of kind of how to talk to parents about if they have concerns about medication. So, parents will sometimes worry that the medicine is going to make their child be a zombie or change their personality. So it's important to kind of reassure that SSRIs don't change one's personality. There can be flattening of affect, apathy, or kind of loss of emotions at higher doses. And so we want to use the lowest possible dose that's therapeutic, but achieving remission. Um, but if that side effect does happen, that could be a reason to think about switching to another medication. Um, and then we talked about this too in terms of, there are risks of not taking medication. So would my child be better off not taking medication? Obviously, if the depression is mild to moderate, I think, starting with therapy alone is a good place to start. But if there are more concerns of kind of impairment with the depression, we want to make sure we're treating it to the best of our abilities. And because there's risks of including suicidality, of not treating the depression. Now, if the first intervention doesn't work, what can we do? So there's some different options. We want to make sure we've had a long enough trial, try at least 4 weeks at an adequate dose. Are we at a high enough dose, right? So if there's been partial response at a lower dose, increasing the dose is always going to be the first step to try before changing medication. But then we can change to a different SSRI or switch to a different class of medication. And then, of course, based on that Tordia study that we talked about, adding therapy if that's not already being done. If we're going to cross taper, I think it's always better to do it kind of conservatively. Technically, fluoxetine has a very long half-life, so you could just, if you're changing from fluoxetine to something else, you could technically stop and start the new medicine. But just to avoid any kind of concerns about side effects with that switch, it's better to do a kind of a cross taper. And so, starting the new medicine at a low dose and tapering down on the old medicine at the same time. Definitely want to do that if you're cross tapering to a different class of medications as well. Um, and because you also want to make sure that you don't create like a discontinuation syndrome accidentally. So, and what that is again, not dangerous, but it's something that can be uncomfortable. Finish is this acronym for it, for the symptoms that can happen. The main thing that people will talk about is kind of electrical sensation on their arms. And you just, want to help them not have something like that. It makes people less likely to want to try medication again in the future if they're having problems starting and stopping the medication. So we want to try to help them not have that. Um, and then the last thing we're going to talk about is if we start medication for a patient and we get to remission, what do we want to do? How long do we want to stay on the medicine? So if this is their first episode or first time treating the depression or anxiety, staying at least for 6 to 12 months after symptoms are improved. And then thinking about a safe time, not a safe time, but a not a time that doesn't have a lot of stressors could be a good time to think about tapering off the medication, like summer break, things like that. And what you'd want to do is decrease by maybe a quarter every 1 to 2 months, and then assess how they're doing with that. Kind of do it slowly. We start slowly. We want to kind of taper off slowly too, and make sure they're doing okay. And the reason is because about half of patients can have a reoccurrence of their depression, and so we want to make sure that we're mindful of not creating that by stopping the medicine too quickly. And just to summarize what we talked about, when to consider prescribing an SSRI in the pediatric setting, kind of some of the practical information about picking a medication and the starting dose, and how to talk about and manage side effects, especially the SI black box warning. And now I have the pleasure of handing it off to Lauren.
Hi, everyone. Thank you for joining us today. So I am going to talk about some CBT basics. So let's see if I can get the slides to work. Okay, great. So we're going to talk about the ABCs of CBT, how affect behavior and cognitions and the environment interact and contribute to mental health challenges like anxiety and depression, just to give it a little bit of a baseline. And then we'll spend most of our time actually talking about how can you all kind of use some of these CBT strategies actually in your office to get folks making change in the right direction. Okay, so the ABCs of CBT. Some of this may seem familiar to you all, but CBT is really rooted in social learning theory, which operates on the assumption that a person's environment, including our personal and cultural background, our dispositional characteristics, like our thinking style, and our situational behavior reciprocally determine each other. Right? And this interaction is an evolving dynamic phenomenon such that our behavior is influenced by our context, and then our behavior in turn influences the context, right? And it's really important for us to consider context because kids and teens with mental health symptoms, that doesn't just happen in a vacuum, right? And so if we're looking at these ABC factors, which do you think is the hardest to directly control? Our affect, our behavior, or our cognitions? And this is often a conversation I'll have with young people when we start to talk about this. Actually, it's our affect, right? And you've probably experienced this if you've ever been upset or sad and someone says, well, just cheer up. Like you can't just change your emotions. And in fact, if you could, I would be out of the job, right? It's actually really hard to just control our emotions. But what we do have control over is our context, what we do or our behavior, and to some degree, how we think. Okay, so before we talk about strategies to change our context, behaviors, and thoughts to improve our affect, it's important to note that unpleasant emotions are not always bad, right? We have them for a reason. Oftentimes they're adaptive and they're effective. They give us information, they can communicate to and influence others, and they can motivate and prepare us for action, such as keeping us safe by prompting us to have a flight, fight, or freeze response in the presence of actual danger, right? So if emotion change isn't our goal, we want to consider validation or other tools, right? So for example, well, it makes sense that you're sad because you miss your mom, right? We don't actually want to change that. It's okay that you're feeling sad. That fits the facts. However, if unpleasant emotions are getting in the way of a child doing the things they want or need to do, such as going to school or participating with their classmates, or the emotions are so extreme that they don't fit the facts, such as causing extreme anxiety about going outside in a safe environment, CBT might be indicated. Okay, so now let's take a look at the common behaviors and cognitions associated with anxiety and depression. So oftentimes, physical and emotional symptoms are associated with negative, internal, global, and stable attributions, which is a fancy way to say glass half empty thinking, right? So those are the thoughts that are associated. And then in terms of our behaviors, anxiety and depression are associated with urges to isolate, escape, and disengage with situations and people that are causing that distress, which results in short-term relief, right? So it makes sense that this happens, but it also eliminates opportunities for environmental reward. And this makes our negative thoughts seem more true, which causes us to feel worse and continue withdrawing and avoiding. So this ineffective cycle occurs and also interacts with the environment when others accidentally reinforce the ineffective behaviors with reassurance and allow escape or too much accommodation. And of course, this happens. Like, nobody likes to see their child in distress. You know, it's our natural reaction as caring people to provide that reassurance and help them. But over time, that makes the cycle worse, right? Slides appear to be sticking again. Okay, great. So now that we've talked through the ABC, what are some key CBT pearls that can help people take charge of their actions and their thoughts to improve anxiety and depression? All right, so fortunately, there are strategies to combat ineffective thinking and behaviors to promote wellness, including cognitive restructuring, and teaching others to resist reassurance and rescue, instead rewarding skill use, right? And this really encourages children to do what we call opposite action, right? So instead of escape, isolate, and avoid, we're going to expose ourselves to those things causing us distress and use behavioral activation to get us engaged with the environment once again. Right? So we're going to actually start there. That's the most active CBT ingredient, opposite action. And again, this is basically doing the hard thing despite the challenging emotion. Okay, so one type of opposite action, again, it's considered the most effective part of CBT, is exposure. Why is exposure so helpful? Well, when we expose ourselves to environments and situations that cause us distress, it helps us build mastery and confidence. It lets you experience the world differently. It proves their worry thoughts wrong, shows that anxiety eventually will go down, gets you familiar with unfamiliar situations, and increases the ability to tolerate uncertainty. And this can be really hard to support youth doing, even though we know it's what we need to do, right? We have to coach parents and caregivers to resist the urge to reassure and rescue. And I have here on the left a QR code for a free online single session intervention available in several languages that teaches parents to do exactly that, teaches parents to kind of resist the reassurance and rescue and instead empower bravery in their children. I also have up here QR coded, and we put in the chat a handout that we created for CalMap that shows how to build an exposure ladder, and it uses the specific exposure of school reentry in the face of school avoidance, given that that's such a common thing that I know comes up in your offices that you can start coaching families through. Okay, so the other opposite action skill that we're going to talk through really quickly is behavior activation. And so this includes activity monitoring and scheduling. Basically, just because when we're feeling depressed, we withdraw and isolate, and that makes us feel worse, we're going to schedule those activities in so that they happen. And it's really helpful too if we bring in the affect. So have youth mood track before and after they do an activity to really see that association of wow, oh, I actually did feel better when I went ahead and engaged with my friends, even though I wasn't feeling like it. And it's also fun to bring in cognitions with something called pleasure predicting. So as you see here on the handout that we created, you can have youth rate how they're feeling before doing an activity, kind of guess, well, how good do you think you're going to feel after doing the activity? And then they try it out and see. And what we often see with depression is they think they're not going to have fun. They think something's going to be really distressing. And then they go out and try and, oh, actually, that was pretty pleasant. And then we also want to bring in the context, right? So it's really helpful if parents and caregivers can encourage these activities, set them up, schedule them for the youth, and also reward it, right? So a really common way that I've seen parents do this effectively with their depressed teens is, okay, I know you really love your screens. It's an escape for you. It makes you feel better. You can earn your screen after you go on the family bike ride, right? And then the last skill we'll briefly talk about is cognitive restructuring. And so one strategy to help change ineffective thinking is something called progressive logical questioning or Socratic questioning, which basically employs a series of questions to draw out youth's unhelpful or inaccurate thoughts and illogical conclusions. And in most cases, their conclusions are very unpleasant or sometimes even silly, like, I may never have any friends again for the rest of my life, right? And so these are some questions that you could even ask in the moment in the office, like, what's a kinder way to talk to yourself? What would you tell a friend in that same situation? Yeah, that could happen. What's another possibility of something that could happen? If that happens, what would you do? Would it be the end of the world, or how would you try to cope, right? And I have a worksheet here that can also help in the moment in the office think through some of these strategies where you get youth to think about, well, what is the thought that I'm having when I'm having the unpleasant emotion? Am I doing any thinking traps like this, like black or white thinking, overgeneralizing, catastrophizing? Let's check that fact. What's the evidence that that thought is true and not true? And then what's a more accurate, balanced, and complete thought in response? Just a note here, we do want to avoid using this strategy if the youth are experiencing oppression. If that's happening, their thought's really not inaccurate, right? So we don't want to challenge it. We actually just want to use validation instead. Okay, and then the last thing is, what if the youth need more than just you coaching them through some of these skills in your office? What does CBT look like, and what are some free resources if you don't, if they're not able to get a referral for that? CBT really should be short-term and goal-based, right? So this is not lifelong therapy coming in once a week, lying on the couch for the rest of your life. Really, we should be having SMART goals, something that's measurable, that means something to that child. There should be a mutual understanding that the therapist has expertise, but the youth is the expert on themselves. And really what's key here is this isn't talk therapy. This is active experiential learning where they're going to go and try these new skills. They're going to do the practice and track it and measure it, right? So you're going to do the activity scheduling, you're going to track it, and we're going to come in and talk about it. That's way more valuable than us just talking about how you feel. Again, we're often including others like caregivers and teachers to really help encourage and reinforce these new skill practices. So that they stick. right? So this is experiential learning, like bicycling or swimming, learning by doing, to get the movement on those SMART goals. And here are some free apps. You probably have heard of Soluna and Bright Life Kids. There's also a cute TBC Triangle of Life app that kind of walks through the ABCs of CBT. And then we also have some great website resources on our CalMap website. I think I did it. I saved time for the questions.
Wonderful. Thank you so much for that great talk. We are about to go into some Q&A, but before we do, I just wanted to be sure that people knew about some of our upcoming talks, including our next webinar happening about a month from today on suicidal ideation. We have a primary care echo series, which is more case-based discussion. You can see some of our topics coming up. And we have a separate echo for school-based audiences that happens on Mondays with some fantastic topics coming up there as well. I wanted to be sure that people have time to, I also wanted to give this reminder that you don't have to carry these questions by yourself. For primary care providers in the audience, you can always call us during office hours, Monday through Friday, 8:30 to 5. Our phone number is here, as well as a QR code where you can place consults online. You can consult our psychiatrists, including Dr. Patel Rao, psychologist. Consultations are also available, as well as resource navigation support. So please do call us or place an e-consult. This is how you claim CME credit for today. I'm going to leave these instructions up here through our Q&A time, just because it might take a little bit of time. And if you could drop the help desk ticket into the chat, in case you run into some technical difficulties with CME credit claiming, please don't struggle with this by yourself. Please use the link to get some help. And so with that, I'm going to turn to some of our audience questions. First question, I think, is for Dr. Patel Rao. Do you recommend a workup for low vitamin D levels or hypothyroidism prior to treating with medications?
I think if there's any other physical symptoms that make you think about those as possible medical causes, then yes, I would definitely do that. Prior to thinking about, even it actually would do that prior to even making the diagnosis of depression, right? So yes, yes.
Wonderful. Can you go over, also for you, Dr. Patel Rao, can you go over the long-term sexual side effects from SSRIs? There were some recent news articles, I think, raising a lot of this concern.
Yeah, and yeah, we saw those recently as well. So, just as a review of kind of the side effects that can occur, and obviously the discussion of this with patients depends on their age and all of that, but there can be concerns about reduced libido, difficulty with orgasm. What is known is that the side effects, or what has been studied and known, I should say, is that the side effects typically resolve it once the medication is stopped. I think those articles talk about that maybe there's situations where that doesn't happen, but that is the understanding is that when the medications are stopped, and that is what typically can be done. So, if somebody is experiencing these side effects, trying to lower the medication or change the medication, sometimes this is a situation, especially if they've had these kind of side effects to multiple SSRIs, to think about changing to a non-SSRI medication as well.
Wonderful, thank you. There was a question that came up about, would you suggest like COX-2 inhibitor like Celebrex over using ibuprofen or naproxen for pain in youth on SSRIs?
I think, and this is where we're talking about short-term use versus long-term use. So if somebody has a chronic pain concern and they need to be on a medication long-term, then I think, yes, something that is, doesn't also carry a bleeding risk would be important to think about. And obviously other specialists would have to kind of weigh in on that as well.
Okay. Um, okay, there are two questions on helping foster youth.
Mhm.
The first one is, does the need for state consent include SSRIs and stimulants, or just like the atypical antipsychotics like Seroquel or risperidone?
So technically, it includes any medication that's being used with a psychotropic purpose. And so even something like Benadryl, if you're using Benadryl for allergies, don't have have to have a JB220 for it. But if you're using Benadryl for sleep or anxiety, then you would be better off, requesting the JV220 consent from court for that medication. So yes, to answer your question, it does include SSRIs and stimulant medications.
In a related way, any suggestions on navigating medication refills for foster youth if you're actually missing that JV 223 form for the judge?
So technically, I review JV 220s for the county of San Diego. Our county has this process where there's a second child psychiatrist who reviews the consent forms, for the court. And so that's one of the things that I do. And so technically, as a new prescriber for that child's medication, you should be submitting your own application to the court for prescribing medication. On that application, there's actually a box that indicates you're requesting this on an emergency basis, which allows you to continue prescribing the medication while you're waiting for the approval from the court, so that you can continue prescribing the medication. The concern about, stopping the medication is a very real concern, and that's a good reason to click off that emergency JV220 box.
Help to maintain the continuity as we're
Absolutely.
writing out the paperwork for sure. Okay, big topic here. AI companions like ChatGPT and their use among depressed or possibly even suicidal youth. What is your opinion?
Lauren, do you want to take a crack at that one first?
Yeah, I mean, this is the wild, wild west, right? Like the technology is coming out and advancing so fast that we don't have data on safety, on guidelines. And we've certainly seen, news stories and anecdotal evidence where this has gone really wrong for folks. And so what I would suggest is we do have evidence on other technology CBT supports, like I linked in my talk. And so I would highly recommend that folks use something that has been studied in terms of safety and has some evidence before using something that we don't know if it works and we don't know if it's harmful. I don't know, Dr. Patel Rao, if you have other thoughts to add on that.
Yeah, the only other thing I would add is, if you have families where the kids are using an AI companion or chat GPT, making sure parents are aware of it and checking the chats, like having an account that the parents have access to as well. I think that part is important as well. And I mean, I think that's true, just in general of kind of monitoring screen time and social media and things like that. I think this falls into that bucket. I agree with you, Lauren, to avoid it if possible. But if you're in a situation where it's already happening, encouraging the families to be doing that. And also encouraging families to have open conversations with their kids about how can you use this, because people are using it for school work as well. And so I think it just is, it goes to that whole idea of digital citizenship and things like that. So
that's a great point. And one of my favorite resources is commonsensemedia.org. It's a website that has a lot of great resources, including like guides or tip sheets for parents talking to their kids about their technology use, just like was just recommended. And so I always give that resource to families to help them think through these tech questions.
Wonderful. Thank you so much for that. There was an ask, what is the site that kids can go on for depression? I'm not sure if there were particular websites. Yes.
I think you're talking about the single session intervention. And so actually what I had linked and QR coded was for the parents. It's called Project Empower, and it's kind of coaching parents how to build bravery in their children. And that same lab for scalable mental health also does have a single session intervention that is evidence-based. And I put that in the chat. It's called Project Yes. It's free. It's available in several languages, and basically helps the youth self-guide through some evidence-based strategies for dealing with stress and distress.
Wonderful, thank you. I want to point out that these are based in cognitive behavioral therapy, so we know those are evidence-based. The state also has a free app called Soluna These are not CBT therapists, these are not licensed therapists, but they are trained wellness coaches who can just, but the real advantage here is with accessibility. It's free, it's accessible via app. This is not AI. These are actual people who can provide a listening ear, some good wellness tips, etc. So that is another resource for kids who might be waiting on therapy resources. So with that, okay, thank you for dropping those resources into the chat. There was another question on whether or not we would have access to these slides and the great resources that are in the slides. So the recording and the PDF of the slide deck will be available on our website, generally within a few business days. So give us a couple of days to get that recording edited and posted, and you should be able to see those resources there. Thank you. And yes. Okay, and yes, and there is also Bright Life Kids for kids who are under 12, and that's more for the parents as opposed for the child themselves. But again, coaches that can provide helpful parenting advice for parents with mental health concerns, uh, sister programs within the Children Youth Behavioral Health Initiative here run by the state. So I want to be sure that everybody knew that those free resources were available. Soluna for teens, as well as Bright Life Kids for the parents of children 0 through 12. There, a question came through about Vyvanse, which is actually not an antidepressant, not necessarily directly related to today, but there might be some misconceptions about what Vyvanse is, since it's actually not necessarily a narcotic. But I was wondering, Dr. Patel Rao, if you could just speak to, like, there's a nuanced conversation to be had, right, about the risks and benefits in general of medications, psychiatric medications, and how you might actually be speaking to parents, families, community members who might have like some real mixed feelings about using psychiatric medication, and especially in light of misuse of narcotics and stimulants and other medications in these categories.
Yeah, no, that's a great question. And I think that's definitely part of that psychoeducation piece. Families will have concerns about, I don't want my child to, get addicted to something or be dependent on it or have to take it forever. Those are all concerns that parents will raise when it comes to thinking about medication. And so I think it's important to just have that understanding, depending on the diagnosis and the medication, for the PCP to have that understanding and be able to talk the parents through those concerns. One of the things I say specifically about stimulant medications, because they are so similar to illegal stimulants that people will abuse. I'll say that yes, they are chemically related, but they're significantly less potent than those illegal stimulants that people can abuse. And talk about how especially the way that some of these long-acting medications are created, like Vyvanse, it's very hard to abuse them. I also, specifically with ADHD, talk about the fact that when we treat ADHD, that actually reduces the risk of those children to develop substance use concerns later in life, because sometimes somebody might fall into abusing substances as a way to self-medicate if they're not receiving treatment. These are also the situations where I'll give families some time to be comfortable with medication, assuming that, there isn't something, kind of drastically impairing about the condition. I'll still recommend starting with, some of the strategies that Lauren talked about in terms of, at home kind of therapy strategies, but and recommend actual therapy. And then give some time for them to sit with, research, come back with questions when it comes to the medication part, not make them feel like they have to make a decision in the moment.
Okay, one last question I think we have time for. Can you comment on use of ashwagandha and perhaps other common integrative therapies in the treatment of anxiety, depression?
Yeah, so it's interesting, because a lot of, things, complementary alternative treatments are unfortunately not FDA regulated. And so it's hard, I think there's families that will want to try something natural, which I can understand. But kind of talking through again that psychoeducation piece of, these things aren't necessarily well studied and well regulated. So you don't actually know what you're ingesting. Is it going to the part of the body that it's supposed to go to, like kind of that concept of bioavailability. I'll talk through that with families. And then also the idea that if something can do something positive in your body, if it's natural, it can also potentially do something negative, right? And so, it is important to think about potential side effects of some of these things. This has kind of fallen out of favor, but St. John's wort was really common for folks who didn't want to use SSRIs, for depression. But St. John's wort does have serotonergic properties. And so if somebody was taking St. John's wort and an SSRI, there was a risk for serotonin syndrome. And so it's definitely important to ask patients and families if they're taking any supplements and just kind of make sure that there's not potential drug interactions with the medications that we're thinking about prescribing. But also just, I think families will try what they want to try. I just want them to have that full knowledge that there could be some side effects and that these things are not regulated. I think those things are important to keep in mind.
Fantastic. Thank you so much for answering those questions. A huge thanks to our speakers, Drs. Patel Rao and Dr. Hack, for their great talk today. Thank you to all of you for coming during the lunch hour and sharing this lunch hour with us. We hope this was valuable for you. Please do come to our next webinars. As previously announced, call CalMap if other questions come up regarding SSRIs or any other medications or general treatment planning or diagnosis with psychiatric conditions. Hope everyone has a wonderful afternoon and weekend. Take care. Goodbye.
Bye, everyone.